Okay, so we have the cerebrum and vascular supply. This slide, I think, is mainly just kind of memorization and knowing. My notes are below, you can look. I went more into depth in what she had. You know, the corona radiata, the corpus callosum, the subcortical structures, knowing what are in the subcortical structures, and then the cortex is just the gray matter on the surface of the hemispheres. She did not really talk about all of them, so I kind of only emphasized on the ones she really did talk about most, and then what I got in the book. The cerebrum, knowing that the cerebrum includes the diencephalon and the cerebral hemispheres. So in the diencephalon, that we have the epithalamus, the hypothalamus, the mammillary bodies, and the subthalamus. There was not much talk about the mammillary bodies. I just had they cooperate with the limbic system. The subthalamus is functionally part of the basal ganglia. The hypothalamus, we already know what that does. The epithalamus does a lot, like with endocrine and like hormones. Something was helpful was epi, PI. So think of PI with epi and pineal gland and pituitary. They all have PIs. So if you remember the PI and the epi, just think, oh yeah, the pineal gland, pituitary gland. So it's got to do something with hormones and endocrine system and stuff. The thalamus, we've learned about this quite a lot. Just remember, it's the selective filter for the cerebral cortex. It regulates the flow of information to the cortex, receives the information from the basal ganglia, the cerebellum, sensory systems, except the olfactory, and then it relays that information to specific areas of the cortex. So how I try to remember the thalamus is it takes all this information and it, makes it into the way that it needs to be specified, and it sends it to those specific places in the brain. The thalamic nuclei. This is the table from the soft chalk that I copy and pasted into my PowerPoint. I did not feel like going and looking at all of them up. So this is just going to kind of be straight memorization. Some of these we're familiar with. Some of these we kind of just have to memorize. We know about the VPL and the VPM. The medial genticulate and the lateral genticulate. I think of these as opposites to what they mean. So medial geniculate is auditory, lateral is visual. Hold on. Oh yeah, definitely know this chart. So I was trying to be like, oh, medial eyes, but that's not it, because medial is ears, lateral is eyes. So if you think of them as the opposite of what they should be, that's how I'm trying to remember them. Some of them some of them are the same. So like the ventral anterior and the ventral lateral, they do the same thing here. And the 2 and 3 on association nuclei, they do the same thing. The only thing I'm concerned about is I can't really see the chart. If someone always chimes in, you can always chime in. I took this chart from Soft Chalk module, but I do want to ask her on Monday if she prefers us to use this table or the one in the book, because the one in the book goes into more specifics of things. So this table, it groups together all of these, the anterior, medial dorsal, lateral dorsal. In the book, it separates them, and it is a little bit of a significant difference. So that is something I want to ask her on Monday is, do we have to know both of them? Can we just know the soft chalk?
Hey, did you guys see a different one? Because this one off soft chalk, it says the non-specific is the MIR. And then in the book, the ones that are color coded, it has the midline one as association. And it just says
oh, really?
specific as IR. So I was like, oh, great.
So the midline is supposed to be with association?
Well, that's what shows in the book. But then midline she has in the soft chalk as non-specific.
That's a good question. We need to ask her about that too.
But let's see real quick. So limbic system.
Yeah, I think it should be with its non-specific.
On the association from the book, it says midline, memory, hippocampus. So they're saying essentially the same thing. They're just in a different category.
That could be something we definitely ask her about.
Okay.
I think the book just added it with the memory section because association deals with emotion and memory.
Right.
So since the midline deals with emotion, they probably just grouped it together.
Mm-hmm.
But yeah, I don't.
That's a good point.
Clarification.
Okay. So we need to ask her about midline definitely, and then some of them go more into specific details on their function in the book. Relay nuclei, think about it conveys the information from the sensory systems, except the olfactory, the basal ganglia, and the cerebellum to the cerebral cortex. So that's a kind of easy one to remember with the thalamus because we always think of it as relaying information. Association, it processes emotion and some memory or integrates different types of sensations. The non-specific is going to deal mainly with the regulating the consciousness, arousal, and attention. And then something I noticed with these was with the association, it goes to places of the cortex, and then those places go straight back to it. Non-specific, it projects to widespread areas of the cortex. So I remember the function, like the reasoning of non-specific, I relate it to widespread. There's not a specific place it goes to. Basal ganglia, movement planning. That's kind of what I'm just sticking with movement planning as its definition. It regulates muscle tone and force. It selects or inhibits specific motor synergies. But if you have all these out of whack, then you're not going to have smooth movement planning. Frontal, all the lobes. So I'm remembering what the occipital, parietal, and temporal are. Like I'm remembering all of these very specific. And if I know that if they give me something that is not one of these, I know it's the frontal lobe because there's so much in the frontal lobe to remember. It can get kind of overwhelming. So I'm looking at the frontal lobe, but I'm focusing more attention on these because there's a shorter amount of things that are in them. I think I got this from the book or from the soft chalk, was just like Contrecoup injuries affect the frontal and occipital lobe. So you get hit in the front of your head, your brain bounces to the back, and it gets damaged back there. Rotational injuries are more devastating because of shearing of axons. Brodmann's areas. I wanted to know more about this and the reasoning for why certain places were certain numbers, but there wasn't a whole lot on it. I think it's kind of just, each place has a number and you kind of have to memorize it. It just maps out what the cortex does and what its functions are. So 5 categories of the cerebral cortex. The primary sensory is going to deal with discriminating among different intensities and qualities of sensory information. The secondary sensory performs more complex analysis of sensation. It's putting the information into a context that we can recognize. Example, recognizing the sound alarm clock is that you need to wake up. Association controls behavior, interprets sensation, and processes emotions and memories. Motor planning is you organize the movements and you get the plan and you put the actions together. The primary motor cortex is you actually execute the movement. So I'll go, an example I think was in the Book of the Bell. So primary sensory, you discriminate the shape and the brightness from the background. Like you see that bell, but you haven't identified it as the bell yet. You just see the shape of it and the brightness of it. Secondary cortex or secondary sensory, you analyze the color of the bell. The association, then you realize, oh, that's a bell. Okay. You remember kind of what sound it makes, specific memories you have with it. Motor planning is the premotor cortex plans the movement. Maybe you're getting ready to go pick it up. And then primary motor is you pick it up, okay, or you shake it, whatever. Okay, so now we go into a little bit more specific with these. Primary sensory, it receives information directly from the ventral tier of the thalamic nuclei, the VPL, which is the body, or the VPM, the face. Primary somatosensory, it discriminates the shape, texture, or size of objects. You're getting exactly what the receptor has to say. These we do need to know the numbers for. So somatosensory is 3, 2, 1. Auditory, conscious discrimination of loudness and pitch of sounds. I included lesions. She didn't really include lesions. I saw them in the book and thought they were kind of just helpful for me. Like if you had a lesion there, what would happen? But they're kind of self-explanatory. Auditory is number 41, the discrimination of loudness and pitch of sounds. The vestibular, 40, it perceives the head movement and head position relative to gravity. Primary visual, it distinguishes intensity of light, shape, size, and location of objects. Visual gives us the sensory information from the retina. Now these, we have to know the location and the number, as well as what they do. My location on this slide is a little bit more in depth. This is what she actually said in the Panopto video. So I put that over there because I don't know if she wants to be as specific as I had in the book. So somatosensory is in the postcentral gyrus. The auditory is in the temporal lobe. The vestibular is right posterior to the somatosensory area, the postcentral gyrus. And the visual is the calcarine sulcus. Secondary sensory. So somatosensory, we have 3 different parts of secondary sensory. Somatosensory is stereognosis and memory of tactile and spatial environment. So you have your eyes closed, someone gives you something, you're moving around in your hands, and then you identify that it's a pen. Astereognosis is the inability to that was weird. Astereognosis is the inability to identify objects by touch and manipulation. With astereognosis, you're able to describe the object, but you're unable to recognize it. Okay, so you can feel and give descriptions of the pen, but you're not going to be able to say it's a pen. So I have some examples of primary versus secondary. Can't remember where I got these from. They might just be me and they might be wrong, but I feel like they are kind of good. Primary sensory, what we were talking about before, it identifies something is there. Secondary sensory identifies that was light touch on my elbow. Visual is the analysis of motion, color, recognition of visual objects, understanding visual spatial relationships, control of visual fixation. 2 areas that could occur here with the lesion is the visual agnosia, your inability to visually recognize objects despite having intact vision, able to describe shape and size of object using vision, but cannot identify objects visually. I just remember that one as when I forget to wear my glasses when I drive. I'm like, I think that's where I should get off. Optic ataxia, inability to use visual information to direct movements. Example of visual, primary and secondary. Primary, secondary, that bright light was from a flashlight. Auditory, classification of sounds. It helps us figure out what kind of sound it is. Auditory agnosia deprives the person of recognition of sounds. Primary auditory, what was that loud noise? That loud noise was from a car engine. this is just kind of describing, I put in the definition of what agnosia is. And then this was in the book. She didn't really touch on it. Prosopagnosia is the unable to visually identify people's faces. That's just highly specific type of visual agnosia. Those, you need to know the general location and the function, but you don't need to know the numbers. Association cortex is abstract thinking and higher level cognitive processing occurs here. Prefrontal association, goal-oriented behavior and self-awareness. Working memory, judgment, planning, abstract reasoning, dividing attention. Lesion, loss of executive function and divergent thinking. If we know prefrontal is goal-oriented behavior, if we have a lesion there, we're not going to be able to do that divergent thinking. Parieto-temporal association, sensory integration, problem solving, understanding language, and special relationships. I think that might be spatial relationships. Okay. Examples, Wernicke's aphasia on the left, but the side that on the right that is, what is it called, analogous to Wernicke's is neglect. Limbic, emotion, motivation, personality, processing of memory. Lesion, disturbances of personality, emotions. Limbic is how are we going to feel about the situation, the sensation we had. So these parts of primary, secondary association, they're familiar in things that we've already learned. They're just, we're kind of having to revisit them and put them in different areas of like where we thought they were before. But I was going over this, I'm like, oh, it's not like completely new stuff. Those, you just need to know the general location and the function. Motor planning. We have the supplementary motor, the premotor, and the Broca's area. Supplementary motor area, SMA, superomedial 6. That's what she said on there. Initiation and planning of movement, orientation of eyes by manual task. It's important in controlling faster, more complex movements. These motor areas, I just kind of understood that if you have a lesion there, it's going to be apraxia. Premotor, lateral 6. So these are both 6. The way I'm remembering this is supplemental motor, S, superior medial 6. So both S's, I know they match. The premotor, you just got to know it's lateral 6. Premotor is the control of trunk and girdle muscles, anticipatory of postural adjustments. Broca's area is 44 and part of 45. It's the motor programming of speech. Planning movements of the mouth during speech and grammatical aspects of language. Lesion is Broca's aphasia, difficulty expressing oneself. Remember that in Broca's, people understand what you're saying, but they just can't communicate back to you what they want to say. Area analogous to Broca's 45, planning the nonverbal communication. So the analogous area to Broca's is going to be in the right hemisphere. This is examples of gestures and tone of voice. And then apraxia is just the knowledge of how to perform skilled movement is lost. I found an example somewhere where it's like putting socks on over shoes. These, you need to know the number, the general location, and the function for each. All of this stuff that I've been talking about, I'm basically just grabbed from these tables. Primary motor cortex, responsible for direct voluntary control, especially fine motor movement and fractionation. Its location is the precentral gyrus. You should already know that. Provides descending control of motor output, corticospinal tracts. Damage can cause contralateral paresis and loss of fractionization of movement. 10 minutes, holy moly. Okay. Dysarthria is a speech disorder resulting from spasticity or paresis of muscles used in speaking. Kayla, can you talk real quick about that question I had in the group me and how I was like, why is dysarthria like, part of this? Like,
The only thing I think of is articulation. So in order to articulate, you have to move the muscles of your mouth, and that's a motor movement.
Okay, perfect. So primary motor is number 4. This is where you're going to execute the work that occurs and the muscles that contract. This is a table I took from Soft Chalk 2. This is talking about disorders of specific areas of cerebral cortex. So this is just a repeat of everything I kind of already said. I did write agraphia is inability to write. Alexia, inability to comprehend a written word. And then, so I'm remembering in the cerebral cortex, we have the 4 A's. In the brainstem later on, we're going to talk about the 4 D's. That's why I kind of got a little bit confused about, why did I see dysarthria? But Kayla had a good response to it. So the 4 A's in the cerebral cortex are aphasia, apraxia, agnosia, and astereognosis. All right. Origin of vascular supply. The aorta is the biggest part of vascular supply for the brain. It's going to be having branches that come from the front and come from the back. So just knowing that where the anterior circulation comes from and where the posterior circulation comes from. Remember here, this says vertebral artery, but remember that before it has the vertebral artery, and then it does form the basilar. Okay. Know what comes off the circle of Willis, but we should already know that because we had Coe's test. The ACA supplies most of the cortex anterior medial surface of brain. It's a large branch of the internal carotid. It supplies the medial frontal lobe to the anterior parietal lobes. The anterior circulation deals with the ACA, the anterior caroidal, and the MCA. So the anterior caroidal is a small vessel that penetrates very deep and travels to subcortical structures. It serves all the subcortical structures that we kind of talked about earlier at the beginning. The MCA is the most common area for stroke, supplies most of the lateral hemispheres. I mean, it has 2 divisions in a deep territory, but in my head, I'm kind of relating the deep as another division, but that's just me. You don't have to do that. The superior division supplies the lateral frontal lobe, the parietal, and some portion of temporal. The inferior division supplies the parietal and temporal. The deep territory, called the lenticulostriate arteries, supply most of the basal ganglia and internal capsule. Deep arteries are very prone to hypertension. Why? Because they're small, and that narrowing results in a rupture called a lacunar infarct. So if it deals with a lacunar infarct, you know that it's dealing with those lenticulostriates because it's deep inside and hypertension. I'll talk about the watershed later, but that's what I put in the group me was hypertension. I'm thinking lacunar infarct. Hypotension, I'm thinking of watershed. So here's the internal carotid coming up. Here's the lenticulostriate going to the internal capsule. The posterior circulation, the posterior cerebral artery, helps provide blood to brainstem, cerebellum, thalamus, inferior medial occipital, and temporal lobes. So posterior circulation, the vertebral artery is the ACA or ASA, the PSA, the pica. How I can explain all this. We know these though already a little bit. The ASA arises bilaterally as 2 branches near the termination of the vertebral arteries descending in front of the medulla oblongata. It supplies the anterior portion of the medulla. The PSA supplies the posterior lateral portion of the lower medulla. I was trying to think of this yesterday, and I was like, I'm just going to remember that both of them kind of form at the medulla, the front and the back, and then they just go straight down after that, and they're supplying the spinal cord. The pica, the posterior inferior cerebral artery, the largest branch of the vertebral artery. It's one of 3 main arteries that supply the cerebellum. This one arises from the level of the medulla and supplies the lateral medulla and inferior cerebellum. Remembering that the basilar gives rise to the PCA. Okay. Basilar artery. You have the ICA, the anterior inferior cerebellar artery, the paramedian arteries, and the pontine. The ICA comes from the level of the caudal pons, supplies the lateral caudal pons and a small portion of cerebellum. The paramedian penetrate into the interior of the brainstem. The pontine perfuse lateral portions of the brainstem. But I did see about Dr. Rogers' email recently to Shelby that they can go in. I'm aware that they can go in. I'm keeping that in the back of my head, but I'm still thinking them as mainly lateral because the paramedian are the ones that really, go in. Cerebellar. Okay, already talked about the ICA, the pontine, the lateral portion of the brainstem, the superior cerebellar artery, SCA. Arises from the top of the basilar artery at the level of the rostral pons, supplies the superior cerebellum in a small region of the rostral and lateral dorsal pons. So this is just going to kind of be like, you have to go back to those anatomy pictures for Dr. Koh's class and really look at, not just look at where they originated like we did, but look at where they're going too. But their names kind of give you, a giveaway of where they're going.
Does the pontine artery supply anything on the cerebellum?
I didn't have anything on the cerebellum.
I didn't either.
Not that I could find.
Okay. Thank you.
Mm-hmm. This is a great picture to look at. Just realizing that, how much of each of these big arteries it actually covers, The way I'm remembering PCA is I know PCA does a lot with the occipital. It's going to do a little bit with the temporal. Why? Because it goes down and supplies the midbrain. Okay. This is a great picture too. Are these covered in the PowerPoint Google slides that Josh gave us? Because these would be good to study. I was thinking about you need to really know these because she could give you a question on the quiz with an X here, and you need to be able to know what artery supplies that part of the brain. This one as well. Oh my gosh, I'm almost there. Okay, knowing that the anterior communicating artery, posterior communicating artery, we already know that. Okay, clinical applications. I'm going to go for another 20 seconds and then we'll probably have to cut off. I will send out another Zoom with my account so we can have the unlimited time. But we're almost done with this one. This won't take much longer. Actually, I'll probably just stop here before. So. Was I too fast? I'm trying to get through this.
No, you were good.
Let me read the chat box real quick because Tiffany had something I probably want to know.
Perfect time.
Now, with your lacunar infarct, you had a rupture. I believe that the lacunar is ischemic, not a hemorrhagic. We might need to look that up again.
Ischemic, I'll talk about it in a little bit. Ischemic can become hemorrhagic.
But I thought lacunar was specifically only an ischemic.
I don't know. That's a good question. I know in my next slides, I do have, I have it in bold, and I'm like, ischemic can become hemorrhagic, but I'm not sure about specifically lacunar.
Now, I know that hemorrhagic can cause ischemia. Like, let's say you've got the MCA goes into your superior and inferior. If you've got one recording now.
Okay.
So let me pull up the Zoom. A hemorrhagic can be an ischemic because, like, let's say you've got the superior and the inferior part of the MCA. If you've got a hemorrhagic stroke right here, there's not going to be any blood perfusion down here. So you can have ischemia with a hemorrhagic, but I don't think you can have a hemorrhagic with a blood clot. Like I don't know. I don't know about that one. We'll have to look that up. But I think I don't know. That's from what I understand. But let's continue.
Okay. Okay, so clinical concept CVA. You have the TIA, the transient ischemic attack. When I'm really remembering this, is it is called a TIA if it is less than 24 hours. The deficits are less than 24 hours. They should have a full recovery afterwards. The problem with this one is it is a significant precursor to a stroke within the next 3 months. Types of CVAs. We have ischemic, which is inadequate blood supply to the area. It's the most common form of stroke. You have types. You have the embolic or the thrombotic. Embolic is a traveling blood clot. It most commonly comes from the legs, the DVT. The thrombotic is the blood clot forms on the vessel wall called atherosclerosis. This is the most common cause of CVAs, is a thrombosis. The internal carotid is the most affected by this type of stroke. Okay. Hemorrhagic occurs from a blood vessel that bursts due to narrowing. Anytime I see hemorrhagic bursting, I immediately think of aneurysm. Okay. The balloon is bursting. That's how I relate them. This is more fatal and damaging because blood is toxic to the brain. Ischemic strokes can convert to hemorrhagic. The way I remembered it was, you're not getting blood supply to that area. Something's blocking it, but what's happening right before that block? It's just accumulating, and it just bursts. That's how I understood it can convert. Aneurysm is abnormal widening or ballooning of a portion. The more growth is the more dangerous. Can become hemorrhagic. And then they talked about here large vessels versus small. Basically, smaller vessels have less damaging effects. If they, only go to this one certain area, that area has, it bursts or something. Whereas if your whole MCA does, you're in way bigger trouble. These are my own notes. I thought they were interesting. They talked about this in integrity videos before the first test. TPAs. You do not give TPAs to hemorrhagic strokes because they can bleed out. TPAs are for clot-busting drugs, or they're clot-busting drugs for thrombotic and embolic strokes. A penumbra was interesting in the book. It's a ring around the tissue death that is reversible. So typically there is a central area of tissue death that is irreversible after a CVA. But wherever the penumbra is, that means there's a little bit of tissue that is still kind of can heal itself. So I don't know if she'll ask that. I just thought it was interesting to know that there's some possible regeneration.
Also, just a little side note, whenever you have a stroke present to the ER, that's why they do a CT immediately, because they will know if it's hemorrhagic or ischemic, and then that'll determine whether they administer TPA or not, just to get it within that 3-hour window.
Oh, that's good to know. Good. Thanks. The homunculus. This thing is disgusting, but you still got to learn it. It just, I don't know, grosses me out for some reason. But you need to know this, where everything is, because where you have that stroke, then you're going to be able to determine by knowing the homunculus what it's going to affect. Okay. So if you don't already have it down, you need to really study this. Okay. So anterior cerebral artery, it's going to be the frontal lobe, the anterior and the medial. With the primary motor, the leg is going to be more affected than the arm. Why? Don't look at my notes.
Because of where the homunculus is.
Yeah.
Homunculus.
This is why you have to know where it is on the homunculus.
The legs are medial.
The lower extremity is more medial. Upper motor neuron signs, the weakness, the hyperreflexia, the hypertonia. The weakness is going to be contralateral to the lesion. Okay, you still don't throw away all the information we learned the past weeks. You still need to know about contra and ipsi, especially in the next couple of PowerPoints. You're going to have effects with judgment. And so you'll have, socially, sexually inappropriate. One time I had an old man that was sexually inappropriate to me and trying to grab me. And I was like, get off me. It's like grandpa. He just had a stroke.
They don't have to be for strokes though.
That is true. Yeah. I let him slide. He was a cute old man, but I did slap his hand. Effect. No facial expression, flat effect. The right hemisphere affects non-dominant language. Apraxia, loss of ability to perform a task despite the ability to understand it. And you're going to have incontinence because you're unable to plan how you're going to void. And then alien hand syndrome, which is super cool. I've never seen it, but I want to see it. I'm kind of obsessed with it right now. But the semi-automatic movements of the arm, not under voluntary control. Middle cerebral artery, the superior division, the frontal lobe. It's going for primary motor. The arm is going to be more affected than the leg. Why? Because the arm is more lateral on the homunculus. Sensation will still be intact. Weakness will be upper motor neuron contralateral to the lesion. Broca's left hemisphere. Okay, you're going to have Broca's aphasia, inability to produce speech. Like I said, the person will still be able to understand you, but they can't, express what they're trying to say. But if it's on the right side, it's not going to be Broca's because Broca's and Wernicke's are only on the left hemisphere. So you're going to have neglect. Neglect with visual spatial problems. Left-sided neglect, you're unaware of the left side of your body. Okay? So if someone asks you to draw a clock, all the numbers are going to be on the right side because it's been affected. You have that left neglect. This is the superior division of the middle cerebral artery. Now we're dealing with the inferior division, okay? Wernicke's. I remember it as Wernicke's word salad. The person is not able to understand the language. I love that video I sent in the group me. I got that one in PTA school and I've always remembered it. That guy is just saying whatever in the world and no one knows what he's saying. He don't even know what he's saying. It's going to affect the face and the arm more than the leg. Why? Because it's more lateral on the homunculus. When you deal with the deep territory of the MCA, you're dealing with the internal capsule and the basal ganglia, pure motor hemiparesis, upper motor neuron signs, contralateral to the weakness. Okay? We already learned about the internal capsule last time. That was, she stressed a lot. That's where the motor was with the corticospinal coming down and stuff. PCA, occipital lobe and temporal lobe. You're going to have a visual field cut. Motor and sensory findings. You have example. You have a stroke of the left PCA. You're going to have a right visual field cut. Same PCA, left side. Left PCA, right side. Watershed. Okay, so watersheds are sites of anastomoses among the distal branches of the cerebral arteries. They are vulnerable to ischemia. They can happen with severe drops in systemic blood pressure, hypotension. That's what I was talking about. I was remembering lacunar infarcts with hypertension and watersheds with hypotension. Why? Because the hypotension decreases the effectiveness of the anastomoses. There's not enough pressure in the arteries to get that blood up to those places. So a lack of blood to the watershed region often causes upper limb paresis and paresthesia. There are two watershed areas. The MCA is in both of them. You're going to have the ACA and the MCA and the PCA. Okay. Our supplemental textbook goes a little bit more in depth about watershed areas if you don't quite understand them. So I really suggest reading that. Okay. It helped me a little bit more and it provided examples, which helped. Okay, videos. She did not talk about global aphasia. I just put it in my notes because I remembered it from PTA school. Remember, global aphasia is when it knocks out the complete left hemisphere. So you take out both Broca's and Wernicke's. It's not just like only Broca's or only Wernicke's. Both are going to be affected. These are in our supplemental textbook. I put these in the Google Slides that Josh made for this PowerPoint because we know when this class is all about clinical stuff, and so I'm gonna really pay attention to these because I almost bet we're gonna have a picture on the test where she gives us this and she says what is affected there. You have to be able to know it's the MCA and it's the superior part, the superior division. So what is it going to affect? Okay. So I kind of broke them up into mine, but I did include these on the Google slide that Josh has for this thing. So I want to do the questions really quick. Let me hide my thing. Okay. You are treating a client who had a stroke in Brodmann's area 17. This person most likely has deficits in
vision. Is it vision?
Visual. Yeah. Good job.
Occipital lobe.
Mm-hmm.
PCA.
All right. A person. Sorry, remind me what SP is again.
Status post?
Oh, yeah. A person's status post an infarct in the right ACA. Right ACA will present with clinical finding. With which clinical findings?
So it mainly tells me motor.
Yeah. Leg more than arm.
Yeah, because it's medial. And then I think of the unable to plan. So like the behaviors, the incontinence.
Inappropriate.
I had left lower extremity affected, and then remembering all those other things, the apraxia, the judgment, the incontinence, the alien hand. I'm just remembering anterior cerebral artery, alien hand. That's what I'm going with.
You were liking that.
It's so interesting.
Could there also be some left neglect too, or would that be more MCA?
Claire, should you say left?
I mean, because
neglect.
I think that would be in the MCA.
MCA. Okay.
Yeah, because I'm relating the Broca's and the Wernicke's are mainly in the MCA area, so that's what.
Yeah, superior and inferior.
Okay.
Okay. The motor planning area located just anterior to the upper body region of the primary motor cortex is called.
I put premotor because upper body is more lateral.
What did I put? Yeah, I did. I was like, I had supplementary arms, but then I was like, premotor? Like, I was kind of like, I don't know what they mean by upper body. So I put supplementary for arms if they're just talking about upper body. And then I also had premotor because I'm like, are they meaning upper body face? Like, so I hope she'll be a little bit more specific on ones like that because you could really go either way.
Yeah, because I guess if you say the premotor, it's more on the lateral side, so it would be more
face. Yeah. Okay. Which major artery in the brain forms at the pontomedullary junction?
SCA.
Put
So
the
we're dealing with the pons and the medulla. So kind of think in your brain about like what it looks like in the pictures that Dr. Ko showed us. Basilar.
The basilar.
Mm-hmm.
Basilar, yeah.
Okay. This last slide is be able to look at illustrations on, imaging and ID where the lesion is. So example of the MRI to the right, would you be able to determine where the damage was with this hemorrhagic event? So I kind of put, definitely it's going to be occipital because you're going to have the it's in the back, the visual deficits. Maybe you're going to have a little bit of the parietal, I was thinking. But I think she's going to do more on this whenever we have the live Zoom session. So that is it for the cerebrum and vascular supply.
Hey, I was wrong on that. An ischemic can become a hemorrhagic. It's called a hemorrhagic transformation. It happens in 0.6 and 3% in untreated patients and 6% of patients treated with the TPA. So that's why they probably have that 3 to 4 hour window for the TPA, because then it really doesn't help much. And there's a greater risk for the hemorrhagic transformation.
Think of the ACA as a mullet haircut coverage. What the heck?
That's what it does. Is it comes from the front and it goes right down the middle. Or not a mullet. I was thinking
A mohawk?
a mohawk. Sorry,
Oh, mohawk.
mohawk is what I meant to say. Sorry.
Oh yeah, mohawk. Yeah, I can totally see. That's awesome. Cool. Who was gonna do the next one?
Did you want me to do it?
If you're up for it, because I took notes on it, but I have not actually studied those two in depth yet.
A lot of it's stuff we already know. It's just kind of hitting the points that he said were important versus the memorization kind of stuff.
Mm-hmm.
Yeah, I feel like all the memorization stuff we know, but like the eye stuff and the reflex stuff is kind of challenging.
Let me see.
Dr. Furtado's PowerPoints were terrifying because he would just say, "Oh, you need to know this." Next slide.
Start off with the cranial nerves. He's got 2 PowerPoints going. The other one's more of the vascular supply. So here is general objectives. Most of it, like I said, we know how to do a lot of this stuff. And I can give you my mnemonics if you don't have a mnemonic for them, just to help you memorize where things like the motor sensory mixed kind of stuff. Well, that's fancy. So these are the general layouts that he'll kind of be talking us through. So this is make sure I get this right, the anterior view here. So the important part for me pulling away from this was that the inferior and superior colliculi are where it's going to connect to the cerebellum. So that's how I'm going to identify that this is the posterior aspect. So that way I know that this is, my reference point. He does make a point that I'll go ahead and add here. Cranial nerve 4 is the only one that comes out posterior, and it's going to wrap around that brainstem and come out towards the anterior side. But we know that the optic nerve and the olfactory nerve, cranial nerves 1 and 2, do not have any involvement with the brainstem. Go ahead and flip over here. This is one of those things that you'll really want to memorize. For the most part, we should have a general idea. I'm going to go back a screen where all these things are, because we know that cranial nerves 3 and 4 are going to come off of the midbrain. 5, 6, and 7, and 8 are all going to come off of the pons laterally. 9, 10, and 12 primarily come off of the medulla, with that cranial nerve 11 kind of generally jumping in there to come out the jugular foramen. But
like 11 was basically from around the spinal cord?
From the spinal cord. It's the spinal accessories. It's going to root off of cranial or cervical nerves 1 and 2 primarily. But it does travel up to meet with cranial nerves 9, 10, and those go out through the jugular foramen. So they do kind of meet up there, but they don't. The primary root isn't off of the brainstem. Okay, so kind of having that idea, we know where these nuclei are going to be. So we still know that, nuclei 3 and 4 are going to be in the midbrain, 5, 6, 7, 8 have to be in the pons, and 9, 10, and 12 are going to be in the medulla, with that 11 coming up off of the cervical branches.
So, Tiffany, when they talk about the pontomedullary junction, that's just right between the pons and the medulla, right?
Correct. So it's this area right here.
The pontomesencephalic is just right
and the pons. Yeah.
Okay.
And make sure you keep those straight, because I always like to jump them around in my head. So make sure you read them very closely. I think it was Shelby who sent us the slides with these kind of blocked out so you can practice them.
Was it Carla?
Carla?
Oh, yeah.
Awesome. Thank you. They are wonderful. Definitely print those off, copy them. He makes a note to, we'll kind of cover that whenever we get there. Just kind of identify where it's at. So we know this is going to be the midbrain here. This is the pontomesencephalic area. That's a little more posterior. So pay attention to those little numbers or those little letters there. This is just kind of a general layout of how the midbrain sits. At this point in our education, we should be pretty familiar with this. Let's see. So cranial nerves does a general description. It's going to supply the motor innervations to the muscles of the face, eyes, tongue, jaw, and neck. Transmit those somatosensory informations from the skin and muscles of the face and TMJ. It's going to transmit special somatosensory information related to visual, auditory, vestibular, gustatory, olfactory, and visceral sensations, and provide parasympathetic regulation of the pupil size, curvature of lens, heart rate, blood pressure, breathing, and digestion. He gets into those a little bit more as he goes along. So it's kind of a general layout of what everything's going to be doing. Clarissa made a great chart. Just memorize it. There's no really easy way to say, here's what it is. Again, at this point, we should know most of these things. I think the only thing that was really new to me was applying the parasympathetic aspect to it. So aside from that, just look over the chart if you can, and if not, make your own chart. So again, we talked about this being the anterior view, and he made a point to say, I think he says it later on, that the cranial nerves all come off anteriorly except cranial nerve number 4, which we talked about. And I believe posteriorly, we're going to have, oh dear, was it the sensation all runs posteriorly? All the tracks and stuff. We'll get to that here in a minute. So again, the posterior view, kind of becoming aware of where some of these nuclei are. So this is where the superior and inferior colliculi are going to connect to the cerebellum. We have the thalamus up in here in the diencephalon. The lateral medial geniculate nuclei. You can still see some of the cranial nerves from the posterior side, but the primary stuff is anterior. Again, kind of the lateral view, just kind of look over this. All right, so olfactory has to do with our smell. If you guys recall from our lovely lecture we had with him, it's going to fit on or sit on the cribriform plate to the olfactory bulb, where it's going to travel to the temporal lobes and hippocampus, kind of developing a sense of smell. We have our vision as our optic nerve number 2. This just kind of has to do with what we see. It's the first input that we'll have. So one thing to kind of note here is that it's going to travel to, so the the visual cue comes in through the pupil to the eye. It's going to synapse onto the optic nerve. The optic nerve is going to go into the chiasm. This is a very generic description of this. I think we get into a lecture that's much more detailed. Some tracts are going to cross. Some tracts are going to stay lateral. So it's kind of something to put in your pocket for later because you'll need that. And then some of these are going to come back and synapse onto the pons. And these are going to be, make sure I said that right. I believe it's the pons. And that's where you're going to have that consensual reflex input. So that's what's going to make it go back through and cause both pupils to dilate whenever we have a light input on one. So the rest of it's going to synapse on the lateral geniculate body, and it's going to travel posterior to the visual cortex. So like I said, that'll get much more detailed, and I can definitely help you guys understand that one once we get there. So the rest of these are going to be the motor aspect, what's going to actually move the eye. So oculomotor, trochlear, and abducens. It is important to note that the trochlear and the abducens only innervate one muscle each. The oculomotor is going to do the other 4. And the oculomotor is also going to be in charge of the reflexive constriction of the pupil. And so we have oculomotor doing the superior rectus, inferior rectus, medial rectus, inferior oblique, levator palpebrae, and papillary sphincter ciliary. So these, oh, my mouse is acting up, sorry guys. These 2, this is going to be lifting the eyelid, and this is going to be constriction. So this is going to be the parasympathetic aspect of it, and that's going to cause a constriction. And these 4 here actually move the eyeball. Then you have the superior oblique, and so this is the one that is the lateral inferior muscle. And I had a hard time connecting in my head why it's called the superior oblique. It's because it's actually going to kind of run around the eye and work on that intorsion of the eye. So it's going to cause it to pull in. So whenever we have a deficit with the superior oblique, that eye is going to, make sure I say this right, I'm getting ahead of myself. It's going to pull down and out. Yes, down and out, because it's not going to have control over pulling it up and in. The abducens is the one that's going to abduct the eye. So whenever we have a deficit with this one, it's going to adduct, so we get that little cross-eyed kind of effect. So he does a really good job describing the eye movements. We were talking a moment ago about the superior oblique. So this muscle, if I recall, make sure I'm saying this right. I'm really bad about saying things and then I confuse myself. Okay, so this guy is going to run kind of underneath and then connect up here. And it's going to help that eye roll up and in. It has a couple little, it's a little bit of an attachment point here that helps double connect that eye muscle in. And then the lateral rectus, like we said, with the abducens, it's going to pull that out to the side. So to test these, we would be doing the H test. And so what you do with that, the big concept, I'm going to go to the next slide, is that the muscles are going to work the best when they're somewhat stretched. So it's kind of like that active insufficiency that we would have, or the passive insufficiency. So at least those are kind of like what we would relate them to in the body. So whenever that muscle is stretched, so his example is looking laterally, all the muscles on the lateral side have all been shortened. So they can't look up or look down anymore because they're all on that lateral side. To test the internal muscles, the upward movement action, you would look laterally and then have them look up. And the muscle action doing the upward motion is going to be that superior rectus instead of the internal oblique. Does that make sense?
Yes, Tiffany, the slide before the anatomical diagram of eye movements, I had in my notes that he said, write out the primary, secondary, and tertiary movements. So is that like the eye goes out and then it goes up? Like the primary is it goes out and the secondary is then it goes up?
So for, I'll do a simple example. So for like the lateral rectus, the primary would be to look out. For the superior and superior rectus and the internal oblique, the primary action is to look up and then to the side. So this looking to the side would be the secondary. So kind of with the few of the rotary aspects, that would be the more tertiary action. So having it roll,
okay,
that tertiary.
That makes sense. Yeah, I feel like I knew what the primary and secondary were. I was like, what is the tertiary? But that's the intorsion or the extorsion.
Mm-hmm.
Okay.
Yeah, so kind of the way that he was describing that, I think, was that. All right. Are you guys good here, or do you need me to explain another one? Okay, I'm going to go on. So that was basically saying what we were saying. All right, so, and here's what we were talking about. Oh my goodness, little fingers. The superior oblique coming up from, so it kind of starts over here, is going to wrap up and around through this ligament and rotate that eye. And so that's why it does that intorsion, is because of the muscle pull itself. You guys let me know. I see there's some comments. Just let me know if I need to stop and comment on anything else. All right. Again, knowing where those nuclei are. So you'll have the oculomotor, and that's going to do those 4 primary muscles, the trochlear coming around and doing, did I follow that one? Okay. Nope, I just brain froze. I was thinking the abducens, that's the one I was trying to follow. The abducens doing that abduction, and the trochlear nerve doing the superior oblique. Or, yes. All right, so we want to be really confident with our ability to identify these reflexes, because this is how we can actually clinically apply what's going on with these cranial nerves. So the pupillary reflex is going to be just shining the light in the eye, and the single eye is going to restrict or constrict. as a byproduct of this, you should also get a consensual reflex, and that's where we had that pathway crossover in the midbrain that we spoke about. So that's where we get that parasympathetic aspect of it. And then accommodation reflex is you place something in front of their face, and then their eyes adjust to the closest object. It's going to cause the pupil to constrict, eyes to converge, and the lens is going to become more concave just to adjust to the depth perception of that. Again, really making sure that you feel comfortable with these. This is kind of the same one that he had, pointing out, however, that the oculomotor and the oculomotor's here, and then down here we have the nucleus of the trochlear nerve here. So the vision tends to be more central. All right. And there we go. So there's his little circles. All right. So we have the trigeminal nerve, which has the 3 branches, the ophthalmic, maxillary, and mandibular. So the first 2 are primary or sensory only, and the mandible is going to be sensory and motor. It's going to be the muscles of mastication, and that's going to be the temporalis, the medial and lateral pterygoids, and the masseter are those muscles of mastication. And he gives a really good picture showing those here in just a moment. The sensory being the discriminative touch, proprioception, pain and temperature of the face, and the TMJ region. All right, so we have 4 nuclei. So the mesencephalic is going to do proprioception from the TMJ. It's going to enter in ipsilaterally, synapse, then it's going to go to the reticular formation, which I guess is in the midbrain. He says it's kind of unknown where it goes from there. The motor nucleus is going to provide the muscles of mastication. It's anterior to the main sensory nucleus. The main sensory is discriminative touch. We talked about this with the trigeminal ganglion, where it enters in, descends. I'm sorry. Yes. No, I'm sorry. This one just crosses at the midline immediately. Sorry, I was getting those 2 backwards. Crosses at the midline and ascends to the ventral posterior medial thalamus, and synapses, then it'll go to the cortex. So the important part is that's in the pons. The spinal nucleus is going to be the pain and temperature. So again, synapsing on to that trigeminal ganglia, it's going to descend. I always think of Damon saying that if you have pain, somebody punches you, have pain, you're going to get knocked down. So you have to descend. Then it's going to cross the midline around the cervicomedullary junction, and it's going to ascend again to the VPM, to the cortex. So we want to make sure that you know that the spinal nucleus is going to go to the medulla. So the medulla is closest to the spinal cord, if that kind of helps you remember that. And then again, here's that picture where he has the temporalis, medial and lateral pterygoids, and the masseter muscles for mastication. Here are...
Don't all the spinal nucleus go down to the medulla?
Do all of them?
I thought that was a common factor.
I haven't spent enough time to...
Yes, Kayla.
Okay.
Because it's the same nucleus as the trigeminal that other nerves are using.
Okay.
Yeah, the facial...
3, 7, 9, 10.
Mm-hmm.
Yeah, something like that.
Good catch.
I'm just trying to find some similarities.
Hey, whatever works.
Okay.
So here's kind of that picture that we've seen so many times. So this one would be make sure I say this right, the main sensory. It's going to go in, cross, and ascend. And then it's going to go spinal nucleus, going to descend, cross, and then travel up. All right. So this one here, we have the lateral aspect for that trigeminal nerve. So you notice that it kind of starts more in the middle. It's going to come out. So this would be the anterior portion. So really figuring out a way to see how the layout is going to be really important. If she just gives us, a cross section, got to know if she puts a lesion here that we're impacting the anterior output versus if she puts something, back here, it's the posterior. All right. So the facial nerve. Oh my goodness. I am not with it today, guys. Sorry. So motor is going to be facial expression, moving the lips, closing the eyes, sensory, touch, pain, pressure from the tongue, pharynx, and skin near the ear canal, and taste to the anterior 2/3 of the tongue. And the parasympathetic is going to be the lacrimal, so the tears, and the salivary glands. So it's important to note that the taste is going to come from cranial nerves 7 and 9. I feel like that might be a good question that she might try to mix us up on. So the facial nucleus, cell bodies of the motor fibers are going to go to or be found in the lower pons. Salivatory, so it's going to be parasympathetic. So the preganglionic cell bodies of the parasympathetic neurons are located here in the pons. The book says medulla, so ignore that. So make sure you note that that's in the pons. We'll see, yada yada. So the solitary is going to accommodate for our taste. The anterior 2/3 of the tongue is going to be in the pons again. The spinal nucleus is going to be spinal nucleus of the 5th trigeminal nerve, and it's going to do sensory information from the ear canal in the oral region, which is the larynx, to the medulla, as Kayla said. So these are all the muscles that the motor is going to innervate. We got a whole bunch of those. We have the salivatory nuclei. It's going to go to the lacrimal gland and the 2 salivary glands. It's submandibular and anybody remember the other one? It's not the parotid. Sublingual. There we go. Sublingual and submandibular salivary glands here. So solitary is going to do taste, and the spinal nucleus of cranial nerve 5. So this one is an area that is more the clinical application. So whenever we have make sure I'm saying all of this. The upper motor neuron is going to control the contralateral aspects of the facial musculature, because one upper motor neuron is going to be traveling to the lower portion of the face, and a different one is going to be traveling to the upper part of the face. So if we have that upper motor neuron, then we'll have the upper, the sparing of the forehead, so we'll be able to lift our eyebrows, be able to use our eyes. We'll just have the lower portion of our face that'll be impacted. For a lower motor neuron, we're going to have ipsilateral effects to the lesion, and because it's going to affect both of the input, it's going to impact the full face. So we'll have decreased forehead motion, or we'll lose forehead motion. We'll have eye drooping, nasal drift, and we'll have the drooping of the side of the mouth as well. So these will be really important to pay attention to. So it's contralateral to the upper motor neuron. You can see over here we have the opposite impact, and that's why we have that sparing that occurs on the forehead, because it's still getting motor input. And the ipsilateral here, you see to the lesion. It's always to the lesion. And you have both inputs that are damaged. Okay, so it's vestibulocochlear. It's going to be our hearing and our balance. So it's going to transmit information related to head movement and position using those semicircular canals. This is an area that we're going to go into a lot more detail in later lectures. I think we have a lot more Furtado lectures coming up over the next 2 weeks. So kind of brace yourself for those. And the cochlear is going to be transmitting information related to hearing. The peripheral receptors are located in the labyrinth, and it's going to contain the vestibular apparatus and the cochlea. All right, so you can see here we have the vestibular apparatus, and this is going to be our wonderful little labyrinth that we're going to get into and talk about. It's going to send it into the vestibular nuclei here in the pons. So it's the last one that's going to be coming primarily off the pons. The rest of it should be down in the medulla. All right. This is just another diagram he gave us. All right, so this is our posterior view. Yes, just making sure I had that correct. So he has a few of the nuclei noted here and where they're going to lay out within the brainstem. So he has this as the oculomotor nucleus space, the trochlear nuclear space, abducens in this area. I don't believe these are specifically like the superior and inferior colliculi being the trochlear nucleus. I think it's just the location within the mid or the brainstem that it's located. So don't let that confuse you too much. All right, so this is going to be that pontomedullary junction. So it's right down here. This is going to be where cranial nerves 6, 7, 8, and 9 all exit. So you can see all of these. So we're talking about the vestibular nuclei. They're going to be up here. The facial nuclei are more medial. The abducens, absolutely the most medial here. I don't know that she'll ask that question, but it's worth noting, kind of those things. And then the spinal tract, as it would have traveled down to this point, it would be in the decusate there. So those are the different cranial nerves that he was pointing out. So glossopharyngeal is the motor to the stylopharyngeus, and that's going to be one of our tongue movement muscles. It's going to provide somatosensation from the soft palate, the pharynx, middle ear, and posterior 1/3 of the tongue, and taste from the posterior 1/3 of the tongue. It has a unique aspect for the autonomic in signaling the blood pressure in the carotid artery and the parotid gland. And in the lectures for he really goes into some detail about where these are located in the branches of the carotid artery, if I remember correctly. So for this one anyways. So just kind of be prepared for that one. And the parotid gland is going to be providing salvation, woohoo, praise Jesus. Are you talking, Kayla? Because your mute's on. You're good? Okay. Okay, so the nuclei. So we have the nucleus ambiguus. It's going to do efferent from the pharyngeal muscles, the spinal nucleus F5, sensation to the middle ear, pharynx, and soft palate. The solitary nucleus. So remember, your solitary has to do with your taste on the tongue. We saw that in cranial nerve 7 as well. The carotid sinus is also involved with this one, and the inferior portion is going to innervate the parotid gland. So these are all located in the medulla. Just kind of make sure. The parotid is the largest salivary gland, and it is this part is in the pons. Just kind of make sure you're familiar with that. So again, we have where all those nuclei are located, where they're running, and where they're going to. So again, the parotid gland, posterior portion of the tongue, the carotid sinus here, the stylopharyngeal here, and some of the middle ear sensation, TMJ a little, and all that good stuff in the pharynx and larynx. Okay, so the vagus nerve, pharyngeal muscles for swallowing and the laryngeal muscles for the voice box. Sensation from the pharynx, meninges and small region of the external auditory meatus, and parasympathetic to the heart, lungs, and digestive tract. Something to note with this one, he was saying that if your patient comes in hoarse, it's possible that they've had some damage to the vagus nerve. And all the parasympathetic input is going to go to the autonomic system. So again, we have the dorsal motor nuclei of cranial nerve 10. Really make sure that you note that this is not a true motor. It's the parasympathetic input to the heart, lungs, and digestive. So the dorsal motor is parasympathetic. Everything else follows more along with what it should. The solitary nuclei, the caudal portion, taste from the epiglottis, nuclei ambiguus, is the motor input to the pharynx and esophageal muscles, and the larynx, and the spinal nuclei of cranial nerve 5, sensation to the pharynx, meninges, and the auditory meatus. And all of these are located in the medulla. So we can see kind of where these are all descending to get to these aspects here. All right. Another fancy picture showing just a little more detail. Did I skip? Nope. Okay. That's what I did. I gotta turn the page over. So again, kind of the parasympathetic, sympathetic aspects, just kind of seeing the sympathetic chain for the sympathetic ganglia, and how those are going to connect. This lecture really isn't about this aspect in particular, just being familiar that parasympathetic is going to have make sure I say this correctly, the preganglionic. So it's going to have to synapse on the ganglia before it can go do the rest and digest aspect, and the sympathetic being, that's what it was, the fight and flight. All right, so spinal accessory cranial nerve 11 is motor to the sternocleidomastoid and the trapezius muscle, and the spinal accessory nuclei in the upper cervical cord. So it's going to start more in the cervical aspect, run up with the brainstem out the jugular foramen here, and then it's going to come out and innervate the sternocleidomastoid and the trapezius muscles here. The hypoglossal is going to innervate the intrinsic and extrinsic muscles of the ipsilateral tongue. The hypoglossal nucleus is in the medulla. So we have our hypoglossal nuclei coming out the hypoglossal foramen next to the foramen magnum. It's going to innervate a lot of these tongue muscles. A lot of the muscles that, nope, that's not correct. Never mind. Ignore that. We have again, this cross section getting down into the lower medulla, closer to the spinal cord here. So we'll have the other half of this, more the medulla aspect of it, and seeing where all of these nuclei are located. Just kind of make sure you're looking at those charts, memorizing these, and seeing how the other tracts are playing into this as well. So we have the corticospinals in there, spinal thalamics, the medial lemniscus, trigeminal lemniscus, and more the solitary nuclei, and a few of the cranial nerve nuclei, more posterior. All right, and going back to that pontomedullary aspect, where we see all of the cranial nerve for 6, 7, 8, and 9 coming out of here. All right, just a different one. Knowing where the lesions are is going to help us understand where the what tracts are going to be impacted and which nuclei might be taken out. So really, really be familiar with this. And again, just the this is the pontomesencephalic area and the midbrain. And again, applying where those tracts are, seeing where they're running, and why they're, if you had a lesion in a certain area, what that would impact. Okay? Same concept. All right. How you guys feeling? It's a lot of information and it's not super detailed. It is super detailed, but it's also vague and just vast.
No, it's helpful though. I appreciate you going through that, especially the eye stuff. Made it a little bit easier.
Awesome. Does somebody else want to do the last one, or you want me to jump into it?
Take it away, Tiffany.
Oh boy.
You do so well with it. I know that I really appreciate you doing this.
I don't feel like I do well. I feel like I start saying things and I'm like brain freeze. I'm like, hold on, wait a second. Just like this next one is going to be, I'm going to try to explain it and hopefully it makes sense. In my brain, it makes sense, but then whenever I try to put it in words, it doesn't always make sense.
Someone commented that we have 23 minutes. I have the time to keep going, so I will. I definitely don't think we're going to make it in 23 minutes, so don't feel like you have to rush, Tiffany. I'd be amazed if you did 20 minutes with this last one. This is like terrible.
We'll see what we can get into. Well, a lot of it's some of the clinical application stuff.
That is true that Furtado did, Brady, but he also told us to go look at most of it.
That's true. That's very true. All right. Let me find the screen share. All right. So the internal structures and the vascular supply. So again, many of these we are very familiar with. This slide, he goes into a lot of information as far as the contralateral versus ipsilateral stuff. So bear with me as I try to explain what's going on here. So if you have a stroke above the midbrain, in the cortex area, and it causes damage in that area before it synapses on the nuclei, it is considered an upper motor neuron, and it's going to have contralateral effects. So if we have it right here, say we have, deep middle cerebral artery infarct right in here. And sorry about that. So we're going to know that it's an upper motor neuron lesion because it has happened before the midbrain and before it has synapsed on any of the nuclei. And so it's going to have contralateral effects. and we're going to have more spasticity. We're going to have the weakness that's noted. And so one aspect of that is going to be really important for the tongue in knowing which direction that tongue is going to deviate. So with an upper motor neuron, when cranial nerve 7 and 10 are impacted for the motor movement of the tongue is going to deviate to, make sure I say this correct, is going to deviate away from the medulla. The medulla, away from the lesion, because the opposite side is going to be innervating the other side of the tongue. Does that make sense? I know it's really tricky. And one way to note that between the upper motor neuron and lower motor neuron is the upper motor neuron is going to have spasticity. So you kind of have like that tongue rolling. They'll have a really difficult time getting their words out and articulating. So whenever I'll say that again, we have upper motor neuron, it's going to come down and the tongue is going to deviate toward the lesion because the opposite side is still being innervated by the opposite side of the motor cortex. So it's going to pull it towards the strong side. Does that make sense? So those muscles on where this would be the left side of the tongue here, are still operating, so it's going to pull it that direction. Whenever we have a lower motor neuron, we're going to have weakness. It's going to be on the ipsilateral side because it has happened after the synapse on the nuclei. So we're going to have the tongue pull in I'll make sure I say this correctly. It's going to pull toward the lesion, this direction, because the motor cortex of the opposite side is still functioning. And so the left side would come, the right side would come down, innervate the left side of the tongue over here, and the aspect is going to pull away from that side, pulling it away from the location of the lesion. Does that make sense? I feel like it was a bunch of words and me trying to get them straight. Y'all good?
That's good.
Okay. I feel like that's going to be one that she's really going to pull from, but it's also really important clinically for us to understand how that's being affected. So we kind of just went over all of these major cranial nerves and such. Another couple things to notice are the cranial nerves 2 and 3 doing the pupillary, consensual, and accommodation reflexes. The corneal reflex, whenever you touch the eyeball with a cotton ball, is going to be afferent for afferent for cranial nerve 5 and efferent for cranial nerve 7. So the afferent is going to be what feels it. The efferent is what's going to cause the eye to blink. So it's cranial nerve 7. And then the gag reflex is cranial nerve 11 touching the back of the throat. That's where you feel it. And the vagus nerve is what causes you to gag. Okay, a lot of information on that one slide that he kind of goes into.
Hey, Tiffany.
Yes.
Isn't it the glossopharyngeal that makes you gag? The vagus is a sensory aspect.
According to his notes, it's opposite.
Okay, say it one more time.
The glossopharyngeal, according to his notes, feels it. And the vagus nerve is what causes you to gag.
Okay.
Is the gag action. So according to his notes, if she says something else, they always put things wrong in the notes, so who knows? So the aspects of speaking, you can have the larynx to generate the sound, and the articulation on the soft palate. You can have the lips that move with cranial nerve 7, the jaw movement from cranial nerve 5 and cranial nerve 12 doing that movement. So Maddie was touching on a little bit of these earlier. So dysarthria is a dysfunction in the muscles that produce the speech. So they have difficulty producing words characterized by poor articulation. So we're saying that, if they had spasticity in their tongue, they're going to have dysarthria because they're not going to be able to produce the actual sounds that they need to make when they're speaking. So causes are damage in the central nervous system or the peripheral nervous system. So it can be weakness, paralysis, lack of coordination of the motor speech system. All right. I'm going to scooch this down so I can see here. So there are 3 stages of swallowing. We need to know that the oral stage is the bolus in the mouth. The pharyngeal laryngeal stage is right as it's at the back of the throat, going down through the pharynx and the larynx. And then the esophageal is just going to be whenever the bolus reaches the esophagus. So right in this area is going to be the oral, pharyngeal, and esophageal. Oh, here we go. I don't think he went into a whole lot of detail on the modified barium swallows. This is a little bit outside of our realm. This is more along the lines of speech, doing these kind of tests, but understanding what they mean can be important too. So dysphagia is difficulty swallowing that arises from muscular incoordination and weakness. So nerve damage to the muscles involved with swallowing, the cranial nerves causing Bell's palsy, central nervous system damage, degenerative or episodic damages, so MS, ALS, or strokes, brain injuries, spinal cord injuries can all impact these. So they gave some good videos of what it should look like and how you're going to respond to those, and the aspiration and residual pooling. We want to avoid that happening. All right. So common cranial nerve findings. He's going to go into a little more detail on all of these: diplopia, ptosis, the impaired smooth pursuit, dilated pupil, facial paresis paralysis, impaired sensation of the face, dizziness, vertigo, tongue drift, dysarthria, dysphagia, and hoarseness. Cranial nerve lesions. So we have a lesion of the olfactory tract. We're going to have anosmia, which is going to affect our ability to smell. As we age, the nerves and the input is actually going to kind of diminish. So we have some anosmia as we age as well. So it can be temporary with infections, permanent with certain head injuries or tumors. It can also be with neurodegenerative conditions like Alzheimer's, Parkinson's. It is progressive, and it comes before the motor symptoms, so they may not even notice what's going on based on their smell. The optic is going to be symptoms of glaucoma through optic neuropathy. We're going to have peripheral vision deficits. It's kind of what you would see if you had glaucoma. So the optic neuritis, inflammation of the optic nerve, is mostly associated with MS. This is going to be varying vision loss and eye pain. The optic nerve atrophy, damage to the optic nerve due to poor blood flow to the eye, disease, trauma, or exposure to toxic substances. I don't think he has too many details on that. So here are a couple of the problems he was talking about before. So the ptosis is dysfunction of the muscles that raise the eyelid. So remember, we were talking about how the oculomotor innervates the levator palpebrae, and so you can kind of see it here in his eye, and hers is definitely more affected. She looks like she has a full case of Bell's palsy going on here with the the nasal drift and the drooping of the side of the lips as well. You can have them with stroke, tumor, or myasthenia gravis. So the cranial nerve 3 palsy, you have that down and out. So complete third nerve palsy, it completely closes the eyelid and deviation. So this one would be complete. I cannot move upward or inward. The pupil is typically enlarged and does not react normally to light. Got to keep moving this little box around. Then the acquired third nerve palsy can be associated with head injury, infection, migraines, tumor, aneurysms, diabetes, or high blood pressure. And this is what it would look like if they were able to open their eyes. Because remember, we talked about how the only muscles that are working are the abducens and the trochlear nerves. So those are both pulling laterally. The oculomotor innervates the other 4 muscles. All right. So we have cranial nerve 4 palsy is the up and out. And so we're talking about cranial nerve 4 being the superior oblique that wraps around, so they can't rotate their eye down and inward. So it's using the oculomotor nerves, it's going to pull up and out because those are going to be the strongest muscles working. So they'll have weakness or paralysis in the superior oblique muscle. Helps if I actually read instead of looking at it whenever I'm describing. Common with closed head injuries. The main pull of the superior oblique is going to bring the muscle down and out. Oh my goodness, looky there. I know what I'm talking about and I'm not even reading. I should read more. So then we have the cranial nerve 6 palsy is going to be adducted because we talked about it being the abducens. So those strong 3 muscles over here of the oculomotor are going to pull that eye in. This is the primary symptom of diplopia. It's be partially caused by overaction of the medial rectus on the unaffected side. Some common causes are diabetes, hypertension, trauma. Posterior fossa lesions are caused by increased intracranial pressure, tumors. You can also see them with MS patients. So these are kind of more drawn out versions of the severity, giving you a little more description. So probably look over those. So for cranial nerve testing, you'll want to know how to do a general idea of what all of these are. So the mastication, are they able to chew? Are they able to have sensation of their face? The corneal reflex, again, touching the eyeball and seeing if the facial nerve causes it to blink. So those 2 are kind of connected here. The facial expression and taste for the facial nerve, vestibulocochlear, you can do a basic hearing exam and the oculomotor exam for positional vertigo. So apparently George Clooney had Bell's palsy, as did Sylvester Stallone. You can see that droop that happens. You can see, I didn't know that George Clooney had it, but you can see the droop on his left side of the face. There's less wrinkles because he's doesn't have the strong musculature to hold it into place. Slight mouth drift, and you can see on Sylvester's as well. All right, so based on this one here, Bell's palsy is also the most common mononeuropathy, and it is idiopathic with cranial nerve 7. So this girl has had an upper motor neuron, and we know that because she has upper sparing. So she has forehead sparing. She can control her eye and her eyebrows, but the lower aspect of her face has been affected. All right, let's see. The cranial nerve testing and finding for the glossopharyngeal vagus is going to be the gag reflex and the swallowing reflex. So both of those are going to be for the afferent limb, being cranial nerve 11, and the efferent being cranial nerve 10, cranial nerve 9, sorry. The vagus nerve is going to be involved with speaking, swallowing, and hoarseness. If you have any of those that are being affected, you'll know that the cranial nerve 10 is most likely involved. Muscle testing of the sternocleidomastoid and upper traps is going to be associated with the spinal accessory nerve, and the hypoglossal is that tongue protrusion. And knowing which way that tongue is going to deviate, and spastic versus flaccid. All right. So do you guys want to go through the cases? Kind of adjust these. So we have a 58-year-old man who comes to your is emergency something? I don't know what ED stands for. Chief complaint of facial drooping. He woke up from a nap and noticed the left side of his face was drooping. His father had a stroke in his late 60s, and he has high cholesterol. The triage nurse has asked if they should activate the stroke team, which means the commencement of imaging and CT, possibly TPA. What do you think? So what do you guys think for this?
Well, he doesn't have the wrinkles on the left side on his forehead. So it looks like it's more of would that be the lower motor neuron, facial nerve?
Mm-hmm. Facial nerve 7, yep. That's it.
So then testing.
Yeah, test facial cranial or CN7.
Yeah, like the corneal reflex, and then the facial expression test, and then taste.
I don't know that taste would have to do so much for this one, because they're still having the opposite side. So it might be hard for the brain to deviate between one side of taste versus the other. But definitely facial expression and the corneal reflex. But I could be wrong on the taste one, though. All right. Whenever I first saw this, like my little blurry pictures, I totally thought this was Bill Nye the Science Guy for about half a second. So a 64-year-old man comes to the emergency department. Why didn't I get that? In the afternoon, chief complaint, facial drooping and slurred speech. His wife reports that the patient's problems were first noticed upon waking this morning, but it progressed throughout the day. Patient has a history of hypertension, hyperlipidemia, and recently suffered from shingles. The triage nurse is asked if they should activate the stroke team. What are you guys thinking? So he's able to make those wrinkles, so he's able to activate here. He does have some drooping here. It doesn't look like he's getting full motor function on the lateral side of the face there.
So that would be the upper motor neuron.
Yeah, is that the upper motor neuron for 7?
Mm-hmm. So he probably needs to activate the stroke team.
Oh, okay.
Get him a CT scan, decide if it's going to be ischemic or hemorrhagic, or we need to do TPN kind of stuff. Not TPN, TPA. TPN is the type of IV food. All right. So going on from there, we have the brainstem and longitudinal sections. So kind of important aspects to be aware of. In the midbrain, you have the tectum as the posterior portion. Being aware of the fourth ventricle, third ventricle, all of this is in here. The cerebral aqueduct of Sylvius. You have the tegmentum. So the tectum is all the way posterior. Tegmentum is kind of more medial in the, I thought there was another name for that, the anterior portion. But here they just have it as different allocations. So we're going to have the motor tracts and the motor nuclei traveling ventrally. So all of this area here is where the motor track's going to be running, and the pontocerebellar axons. Then we're going to have the tegmentum running dorsally.
The green portion, I just assumed that was the basilar because it's the ventral part.
Okay, yeah. Oh, I have the little box in the way, so I was not even looking at the word. I missed the word. That's why I'm like, I know there's a name to it. Yes, so the basilar area here, the tegmentum and the tectum. So in the tegmentum, we're going to have the reticular formation, the sensory nuclei, sensory tracts, cranial nerve nuclei, and the medial longitudinal fasciculus. So knowing that this is where most of our cranial nerve nuclei are going to be. And the tectum is the pretectal area in the superior inferior colliculi here. That's going to help connect in the, I think it's in here, the cerebellum. All right. So again, just another demonstration of the different tracts. So we have all the red motor tracts here, and then the sensory tracts posterior. All right, another example of that, knowing that the reticular formation kind of has a bilateral direction that it runs throughout there, the cerebellum, cranial nerves, all that good stuff. The reticular formation being the center of the tegmentum. So we want to know this is complex neural network, including the reticular nuclei and their connections and ascending, descending pathways. So in the rostral portion, it's going to be the main alert in conscious state. Then the caudal portion is going to be the motor reflexes, autonomic functions, or motor and reflex and autonomic functions. So knowing rostral meaning superior basically, and caudal meaning more inferior. The rostral portion is also going to have our sleep-wake cycles. This kind of just shows the general layout throughout the layers. So the caudal really being more the pons and below, and the rostral being the superior pons and the midbrain. All right. Move my little boxy here. So the vertical tracts in the brainstem, again, we talked about the dorsal column, medial lemniscus, the spinal thalamic, spinocerebellar, and trigeminal lemniscus. So those are all those lovely sensory tracts. The motor are going to be anterior. It's the corticospinal, corticobulbar. They're going to run from the cortex to the cranial nerve nuclei to innervate the muscles of the face, and the corticopontine. All right.
He did say we didn't have to know much about the corticopontine, right? I have in my notes that it just runs with the pons, but he said something like you don't have to know that yet.
That lovely word yet. Yes.
Okay.
Yeah. I just have that it communicates with the cerebellum. Is what I had in my notes.
Okay, perfect.
So we're getting into the disorders of the brainstem. So you're going to want to be able to evaluate the function of the cranial nerves and the vertical tracts. A mix of ipsilateral and contralateral signs. Why does that happen? So for, like we were talking about with the upper motor neuron, it has a bilateral projection for the upper portion of the face and contralateral for the lower portion of the face. So that's why you need to know how those signs are going to present versus Bell's palsy being lower motor neuron just affecting the entire half of the face. Vital functions and consciousness. So these are really important because, you can die with these not working correctly. The heart can stop beating, blood pressure fluctuations, and breathing can cease. The 4 Ds of the brainstem are going to be the dysphagia, dysarthria, diplopia, and dysmetria. He, I think, had a little bit of a slip of the tongue there, and said that dysdiadokinesia is part of the 4 Ds. It is not, especially if you're comparing it with the soft chalk, because that question is in the soft chalk as part of the 4 Ds, and it is not. So really disconnect that. So dysphagia, dysarthria, diplopia, and dysmetria is in that locked-in syndrome. It's another one of those where they're able to move their eyes, but they've had brainstem, spinal cord injury, and they can't do or express anything else. The only nerves that are working are usually their eye muscles. So disorders with consciousness occurs with brainstem and cerebrum disorders. The states of consciousness are going to be the coma, vegetative state, minimally conscious state, stupor, and obtunded. So we really want to make sure that we know the difference between these. So a coma means that they are unarousable. There's no response. They may have some altered respiration, reduced basic reflexes such as coughing and swallowing. Vegetative state is a complete loss of consciousness without alteration of vital functions. The differences between it and a coma is that they can open their eyes, they have regular sleep-wake cycles, and they have normal respiration. Minimally conscious state, they have a severely altered consciousness. They can do at least one of the following. They can follow a simple command. They can gesture. They can answer yes or no. They have intelligible speech, or they can do a movement. Stupor means that they're unarousable by strong, or arousable only by strong stimuli, able to function when awake, but very hard to keep awake. And obtunded means that they're sleeping more than awake, drowsy, and confused when they're awake. This is what happens to me when I take Benadryl. So I have the worst time dealing with Benadryl. All right, so the anatomy of the lower medulla. Again, kind of just knowing where these are and what they're going to mean for us. So we had the fasciculi of the dorsal column tract. Over here, going to be able to, I'll make sure I said that right. Okay, so this is where the fasciculi are, and they're going to synapse on the nuclei, and then they're going to decussate in those internal arcuate fibers over to the medial lemniscus tract. And so just kind of seeing how those tracts are playing out and what they're going to be implementing if one of them is damaged. So the upper medulla, we have the spinothalamic, trigeminal lemniscus, medial lemniscus, cranial nerve 12, the Raphe nuclei, or Raphe nuclei, hypoglossal nucleus. I think I pointed at one of these incorrectly. Oh, that's the same. The vestibular nuclei, the solitary nucleus, and the dorsal motor nucleus of the vagus. All right, in the pons, we have the vestibular nuclei, the trigeminal nuclei here. We have the anterior spinocerebellar tract, middle cerebellar peduncle, rubrospinal, spinothalamic, and seeing how small those are in comparison to like the cranial nerves at this point in time is very interesting. Medial lemniscus tracts, and the corticospinal, corticobrainstem, corticopontine tracts. All right. So we have the superior colliculi, so we know that this is the posterior aspect. We have the periaqueductal gray and the cerebral aqueduct, we are at the level of the midbrain. So these are going to be important for the functions of movement, especially with the eye and auditory and visual processing. So we have, I lost my mouse there. There it is. Ocular motor nuclei, the red nucleus, substantia nigra, corticospinal tracts. These kind of all are mixing in together a little bit. So trigeminal lemniscus and all that fun stuff. Again, with the arterial distribution, so we have the posterior cerebellar artery, the superior cerebellar artery, cerebellar artery. Does anyone know what this nerve here is?
Ocular motor.
Ocular motor. All right, so we have the basilar artery, the anterior inferior cerebellar artery, and the posterior inferior cerebellar artery, vertebral arteries, and the spinal anterior spinal nerve. All right. How are we doing on time? So these are, again, kind of just ones that you'll want to memorize, that distribution. I haven't quite looked at all the slides that you guys have done yet. There's so much great input. I have a hard time getting through all of it. But knowing, the superior cerebellar artery and the proximal posterior cerebral arteries are going to provide blood flow to the dorsal aspect. The proximal posterior cerebral artery is going to provide the brainstem and the ventral aspect, and some of those paramedian branches from the top of the basilar artery, and then just kind of seeing where all the little tracts are running. For the rostral pons, we primarily have the superior cerebellar artery impacting up here, the basilar arteries with the circumferential branches and the paramedian branches, ICA, and the basilar is going to be more towards the caudal pons, so the anterior, inferior, and basilar providing those circumferential branches and the lateral pontine arteries, and then the basilar artery providing the paramedian branches. The vertebral and the posterior inferior cerebellar artery, providing that lateral aspect. Vertebral artery really providing that lateral, anterolateral aspect, and the anteromedial, or just a really medial area of the vertebral artery and the paramedian branches, as well as the anterior spinal artery. So some of the syndromes that we can have, the lateral medullary syndrome, also known as Wallenberg syndrome. This is going to be from a vertebral artery thrombosis or in the pica. So it's ipsilateral ataxia, vertigo, nystagmus. You guys know what nystagmus is. They have a hard time tracking. You kind of have that jumping pupil. They'll have nausea, impaired pain and temperature from the contralateral body and ipsilateral face, ipsilateral Horner syndrome, dysphagia, and hoarseness. Horner syndrome results in a decrease in pupil size, a drooping eyelid, and decreased sweating on the affected side of your face. He did say that in the book there's a really good picture for these, and it's kind of talking about these charts here. It's on page 367. So the most frequent site of brainstem stroke is the lateral medulla, and this is going to kind of line out what all would be affected with that kind of stroke. Vertebro-basilar vascular syndromes. So this is more the ICA syndrome, or the caudolateral pons. It's going to have ipsilateral ataxia, vertigo, nystagmus, nausea, impaired. Did I go back a slide? No, it's the same thing. Okay. It's like I could have swore I just read this. The ipsilateral face, ipsilateral Horner syndrome, dysphagia, and unilateral hearing loss. So that's one of the key differences. So with the pica, you had more hoarseness. I'm gonna fall off my little ball. And with the ICA, you're going to have hearing loss. So kind of determining differences there. So again, this is the second most frequent site of stroke for the lateral inferior pons. Seeing how these little charts are going to explain where everything's affected. This chart was on page 368. You guys need to know that. And this one is the most frequent site of the brainstem stroke. Or I'm sorry, not brainstem, midbrain stroke. The basilar artery affecting the anteromedial midbrain. And again, making sure that you're just reviewing these charts, looking at the impact of all of these. Sorry, and I think I just jumped a slide. And feeling comfortable with where these lesions are located and how they would present. And the last one being the basilar artery stroke is the most severe and frequently fatal. Motor deficits, including hemiparesis, tetraparesis, and facial paresis in 40 to 67% of cases. Dysarthria, speech impairment, vertigo, nausea, vomiting, headache, visual disturbances, altered consciousness due to the impact on the reticular activating system, can affect the cranial nerves. The differential diagnosis may result in crossed findings, meaning ipsilateral cranial nerve loss and contralateral motor sensory loss. And if it's massive, they can have that locked-in syndrome, head-to-toe paralysis, and loss of speech. All right.
Tiffany, can you go back to slide 40?
Sure thing. Oh, wrong one. Don't look at my quiz, guys. Sorry. It's the only bad thing about Max is it pops at the bottom. All right. So slide 40.
The one right before that one. Yeah. So, for me, when I'm like reading all this, it's really easy for me for my eyes to just glaze over. Something that's helping me is remember. So this is a Wallenberg's, the lateral medulla. The Wallenberg's deals with the pica, the posterior inferior cerebral artery. Think about it. It's posterior, and it's going to, or cerebellum. Sorry, it's going to the cerebellum. So think about the artery that's affected in that area, and it'll kind of give you a little bit of a hint where it's going to be affected, in the medulla or in the midbrain or whatever it is, because, and then go to 43. Yeah, that one. So this one's talking about the midbrain. Well, look where it's at. It's in front. Well, that's because the basilar runs up the front of the pons and also the front of the midbrain. So if you remember the arteries and where they kind of, where they go to supply blood, you know that it's going to affect that certain part. So you don't have to be like, well, I can't remember, like, what's there. Just remember, like, what artery is affected and where it runs. I don't know if that helps anyone. It's been helping me, but
Definitely every little bit helps. Is there any other ones?
Hey, Maddie, did you get immediate grading on your quiz? I'm